Welcome to Everything Medical. Today's video, we shall be looking at the anatomy of the knee joint. So this diagram shows us how the knee joint is being fashioned on the body. This is the anterior view of the knee joint, while this is the side view of the knee joint or the lateral view. Now, before wasting much of our time, we are going to dive into the class. But before we continue, if you are coming across to my channel at the first time, enable to subscribe so that you get notification when I upload video on human anatomy. The first thing first is the introduction. What is knee joint? Knee joint is a synovial joint of modified hinge variety. It is a synovial joint of modified hinge variety. It is not a typical hinge synovial joint because it permits or undergoes variety of range of movement, which is an automatic or conjunct rotational movement when the knee is flexed and extended. So that is why it is not a typical hinge synovial joint, because it permits an automatic or conjoint rotational movement when the knee is flexed and extended. The knee joint is one of those complex and the largest joint of the body because it's known as the weight bearing of the body. It mostly bears the weight of the whole body. That is why it is prone to degenerative complications leading to osteoarthritis. That is why if you watch older persons, either men or women, they mostly suffer from osteoarthritis because there is always a degenerative articular cartilages of those joints. That is why it is prone to osteoarthritis, which is the inflammation of the articular cartilages of the knee joint. But then, the knee joint is a compound joint as well. It is a compound joint because it is being formed by 3 articulations. Before I dive into the articulation, let's look at this diagram. The knee joint is formed by 2 bony articulations. The upper aspect is the femur. The lower aspect is the tibia. The fibula does not form any true articulations in participating in forming the knee joint. So, but let's indicate it. This is the fibula. Now, let's come back to what I said, that the knee joint is a compound joint consisting of 3 articulations. It's formed by 3 articulations, which is the right and left condylar joint between the condylar or between the condyles of the femur and the tibia, because it is between the condyles of the femur and the tibia that forms the right and left condylar joint, and one saddle joint, which is the joint between the patella and the femur, called the patellofemoral joint or the femoropatellar joint. So the knee joint comprises of 3 compound joints that forms it together. We have the right and left condylar joint, which is being formed between the condyles of the femur and the tibia, and one saddle joint. Now, look at it here. This is the right and left condylar joint that is being formed by the condyles of the femur and the tibia. And here, there is a joint that exists here. There is a joint that exists at this region. And that joint is known as a saddle joint, but it is being particularly called the patellofemoral joint. It is being called the patellofemoral joint. That is how it is being what? Done. So that is it. Now, here shows us the two condylar joints that is being formed by the condyles of the femur and the tibia. Now, this region indicates one of those condylar joints, which is the lateral femorotibial joint. The lateral femorotibial joint is one of those condylar joints that is being formed by the condyles of the femur and the what? The tibia. Now, this region is the medial femorotibial joint. So these are the joints that forms the compound articulation of the knee joint, inclusively with the patellofemoral joint, which is a saddle joint. That means we have two joints that forms the knee joint complex. The condylar joint, which is the lateral and medial femorotibial joint, and the saddle joint, which is the patellofemoral joint. So here in this region is patellofemoral joint. It's a saddle joint. Why this and this is a condylar joint. So that is how the knee joint is being what? Fashioned on their articulation complex. Recall that it is a compound joint. And the next outline we shall be looking on is the articular surfaces, because it is a joint. It must have an articular surface. The articular surface on the articular surface, it has four articular surface. Number one is the articular surface of the medial and lateral part of the femur, the medial and lateral condyles of the femur. That is the number one articular surface. The articular surface of the medial and lateral condyle of the femur. The number two is the trochlear surface of the what? The femur. The trochlear surface of the femur. That is the number two. The trochlear surface of the femur. So let's pen it down. Let's pen it down. Number one is articular surface of medial and lateral condyle of femur. The number two is trochlear surface of femur. The number three is the articular surface of the patella. The number four is the articular surface of the medial and lateral condyle of tibia. Of tibia. Now, these are the articular surfaces of the knee joint. So, the articular surface of the medial and lateral condyle of the femur consists of the anterior and posterior and inferior condyles of the femur. You get, and it is convex. It is convex on its anterior posterior aspect. It is convex on that region. You get, and something convex means something that is arched or rounded. It has an arched surface or rounded surface. You can call it a mere surface. Now, the trochlear surface of the femur is located at the what? At the anterior aspect of the lower part of the femur. You get, or the lower end of the femur. You get, it articulates with the posterior aspect of the articular surface of the patella. You get, that is what that articulates it, because the trochlear surface of the femur is located on the anterior aspect of the lower end of the femur. That is where it is being located, where it articulates with the what? With the posterior aspect of the articular surface of the patella. Now, the articular surface of the patella is located on the what? It is located on the posterior aspect of the patella, where it articulates with the trochlear surface of the femur. That is how it is being what? Fashioned on that joint. Now, the articular surface of the medial and lateral condyle of the tibia is an important aspect as well. You get. So these are the articular surfaces of the what? Of the knee joint. So that is how it is being what? Fashioned. The next we shall be looking on to is the stability, because it is a joint. It must have a stability. Something must do what? Must stabilize it. It must have a what? A stability. To have the stability, the stability. The number one stability it has is it has an important stability. Number one is the strength of, or the strength and action of the surrounding tendons and muscles. Strength and action of surrounding tendons and muscles. Why does it has the strength and action of the surrounding tendons and muscles? Because that there are so many tendons that surrounds the what? The knee joint. For example, the tendons of quadriceps femoris, that is the quad muscles, because they insert on the patella. So they help to stabilize the what? The knee joint. So that is why it has to be its stability. The strength and action of the surrounding tendons and the what? And the muscles. Now, the next stability is we have the number two, the cruciate ligament. The cruciate ligament maintains anterior posterior stability. You get the cruciate ligament. The cruciate ligament maintains anterior posterior stability. Recall that we have the cruciate ligament, you get, which is two cruciate ligaments. You get, they help to maintain the anterior posterior stability of the knee joint. And if there's any injury to those cruciate ligaments, either by the posterior or the anterior dislocation of the tibia, you get, there could be hypermobility of the anterior posterior movement of the knee joint. That is why the cruciate ligament helps to stabilize it. And these are the cruciate ligament, because we have the anterior and posterior cruciate ligament. The anterior and posterior what? Cruciate ligament. They help to stabilize the anterior posterior activities of the what? Of the knee joint. So that is it. The number three is The collateral ligament maintains side to side stability. You get, because we have the medial and lateral collateral ligaments, which can be called the fibula and what, and tibia collateral ligament. The fibula is lateral, the tibia is medial. Get, they help to do what, to maintain side to side stability. So the collateral ligament the collateral ligament maintains side to side stability. So I've explained why it is needed on the knee joint, because they are located on the both sides. This is the fibular collateral ligament, which can be called the lateral collateral ligament. Here is the tibial collateral ligament, which is being divided into two aspects, the deep and the superficial part of it. This is the deep, this is the superficial. You get, it's an important word, ligament. Now, the next, which is the number 4, stability, is the iliotibial tract helps in stabilizing the knee joint when it's partly flexed. You get, the iliotibial tract helps in stabilizing the knee joint when partly flexed. So that is the stabilities of the what, of the knee joint. But you have to note that the knee joint on its structural arrangement, the knee joint is what, is relatively weak because of the incongruence of the articular surface. You get, the knee joint is what, relatively weak because of the incongruous nature of its articular surface. Look at it here. In the incongruous nature of its articular surface, because the tibia condyle, these are the tibia condyle, okay, which form its articular surface. The tibia condyle is what, is small and shallow to accommodate the large convex femoral condyle. That is why it is what, it is not, had it been the stability, it is not active, because the knee joint have a strong stability. That is why it is able to hold it in place during flexion and extension of its movement, because flexion and extension is the main or the active movement of the knee joint. You get, so that is why it has those numerous stabilities, because the tibia condyle is small and hollow or shallow to accommodate the large convex femoral condyle. Yes. So that is how it is being done. Even the patellofemoral articulation, which is between the patella and the femur, is also weak. What that holds the knee joint in place is actually those stabilities that we have just mentioned. Yes. So to tell you that stability of a joint is very, very vital. Is a vital one of its activities. So the next we shall be looking on to is the ligament. It is a joint, it must have a ligament. So the ligament the knee joint has numerous ligaments. It has what? Numerous ligaments. Number one ligament is the capsular ligament. The capsular ligament. And here is the capsular ligament. This is the capsular ligament. the capsular ligament. Here also are the capsular ligaments, because the capsular ligament is a thin fibrous sac that surrounds or encloses the joint cavity. Capsular ligament, you get, as the capsular ligament. The number 2 ligament is the ligamentum patella, which is an insertion of the tendon of the quadriceps femoris. You get the ligamentum patella. Patellum. The number 3 is the collateral ligament, which is the medial and lateral collateral ligaments. The number 4 is the cruciate ligament, the anterior and posterior cruciate ligament. The number 5 is an important ligament, which is the medial and lateral menisci. Medial and lateral menisci. Now, these are the principal ligament of the knee joint. We have the secondary ligament. We can call this the primary ligament of the knee joint. We also have the secondary ligament or the accessory ligament of the knee joint. So let's pen it down. The secondary ligament. The secondary ligament of the knee joint. Number 1 is the oblique popliteal ligament. The number 2 is the arcuate popliteal ligament. And number 3 is the transverse ligament. Transverse ligament. The number 4 is the coronal ligament. Coronary ligament. So these are the secondary or the accessory ligament of the knee joint. Why these are the primary or the main ligament of the what? Of the knee joint. Now let's start with the capsular ligament. The capsular what? Ligament. From the name capsular, you should know that it is a tissue that encloses a particular structure on the knee joint. So the capsular ligament is actually the thin fibrous sac that surrounds or encloses the joint cavity. It is deficient on its anterior aspect, where it is being replaced by the patella, the quadriceps femoris, and the ligamentum patellum. So that is all about the capsular ligament. As I've showed you, it encloses all the structures of the what? Of the knee joint. Look at the capsular ligament. It encloses these internal structures of the what? Of the knee joint, so that it will not, like, it actually maintain its what? Stability. You get? Because it encloses those structures on inside it. Now the next one is the ligamentum patellum. The ligamentum patellum is actually the insertion of the tendon of the quadriceps femoris muscle. You get? Which extends to the apex of the patella towards the upper part of the tibia tuberosity. Now watch here. This is the ligamentum patellum. The ligamentum patellum. You get? It is actually the what? The insertion of the tendon of the quadriceps femoris muscle, the quad muscle, those muscles that forms the anterior or the extensor compartment of the thigh, which includes the vastus muscles. You get the vastus muscles. So they are one of those muscles that forms it what anterior compartment, and also the bicep what femoris. You get. Now, this is the quadricep femoris muscle. The quadricep femoris muscle. The quadricep femoris muscle. So the tendon continues that because it inserts at the what? At the patella. Get. And that is why we can call this ligamentum patellum the what? The tendon of the quadricep what? Femoris muscle. So the ligamentum patellum, which is this, ligamentum patellum, the ligamentum patellum is the insertion of the tendon of the quadricep what femoris. You get, which extend from the apex of the patella. It extends from the apex of the patella to where it is being what, or to the upper part of the tibia tuberosity. Here is the tibia tuberosity because this is the tibia bone. Here is the what? Tibia tuberosity. You get. So that is how it is being what? Arranged. Now, the next we shall be looking onto is the what? Is the collateral ligament. We have the two collateral ligaments, the medial and the lateral collateral ligament, which can be called the fibula and the tibia collateral ligament. Now, watch here. Here is the fibula or the lateral collateral ligament. The lateral or fibula the lateral collateral ligament, which can be called the fibular collateral ligament. While on this region is the medial collateral ligament, which can be called the tibia collateral ligament. It can be called the tibia collateral ligament. Get. Recall that the tibia or the medial collateral ligament is an important ligament. You get. It is a strong, long, thick, and flat band of fibrous tissue. It is a long, it is a strong, it is a thick and flat band of what? Fibrous tissue. You get, which is being divided into two parts, the superficial part and the deep part. Here is the deep part of the medial collateral ligament. Here is the deep part of medial collateral ligament. While here is the superficial part. The superficial part of medial collateral ligament. That is how it is being what? It is being done. Recall that it is a what? It is a strong, long, thick, and flat band of fibrous tissue. You get it. It also helps in maintaining the activities of the what? Of the knee joint. You get. It helps in maintaining the what? Activities of the knee joint. Likewise, the lateral collateral ligament. The lateral collateral ligament. The next is the cruciate ligament. The cruciate ligament is like there are two thick, strong, fibrous bands. You get? There are two what? Thick, strong what? Fibrous bands that are said to act directly as a union bond between the femur and the tibia. As you can see, this is the cruciate ligament. The cruciate ligament is divided into two according to where it attaches on the femur and the what? The tibia. The cruciate ligament divided into two, which is the anterior and posterior cruciate ligament. Now, here is the anterior cruciate ligament, while here is the posterior cruciate ligament. The cruciate ligaments are located inside the knee joint. They are located what? Inside the knee joint. Get. Recall that they are strong. Get. They are two thick, strong fibrous bands that are said to act directly as a union bond, between the what? The femur and the tibia. They are located inside where? Inside the knee joint, where they help to maintain the anteroposterior stability of the what? Of the knee joint. Recall that the anterior cruciate ligament is more prone to what? Is more what? Prone to injury. And injury to the anterior cruciate ligament will lead to hypermobility of the anteroposterior activities of the what? Of the knee joint. Recall that the anterior cruciate ligament is more intracapsular, you get, and it is what? Extrasynovial. It is an intracapsular structure, but it is an what? Extrasynovial structure. That was an important what? Clarification. That is how it is being what? It is being done on the cruciate what? Ligament. Now, the medial collateral and the medial and lateral menisci, let's discuss this. This is the lateral menisci, while this is the medial meniscus. The medial meniscus. You get. So two of them are menisci. Menisci is plural. Meniscus is what? Singular. So the lateral meniscus and the medial meniscus. Now, what is all about this? You get. The meniscus are just like a semilunar cartilage. You get. The meniscus is a semilunar cartilage. There are two crescent-shaped inter-articular structures that is being formed by a fibrocartilage. You get. That is being formed by what? A fibrocartilage. There are crescent-shaped inter-articular disc. As you can see, they are like a disc, inter-articular disc that is being formed by what? A fibrocartilage. They have a thick peripheral outer border and a thin inner border. What do? They help to deepen the articular surface of the tibia condyle, where they help in partitioning or dividing the knee joint into two compartments: the upper meniscofemoral compartment and the lower meniscotibia compartment. Let's watch it. Now, this, be it the medial meniscus or the lateral meniscus, it divides the knee joint into two compartments: the upper meniscofemoral compartment and the lower meniscotibia compartment. Now, watch. Here on this region is the lower meniscotibia compartment. The lower meniscotibia compartment. You get the lower meniscotibia compartment. Why up here is the upper meniscofemoral compartment. So to tell you that it is this interarticular disc which is the what? The meniscus, helps to compartmentalize the knee joint into two compartments, the upper and lower menisco temporal, the the upper and lower menisco femoral and tibia compartment, not temporal. That one is in on the what? On the TMJ. Now, recall that we have discussed this, be it the medial and the lateral menisci. Yes. Although the lateral meniscus is quite different from the medial menisci. You get? Because the medial meniscus and the lateral meniscus have different shapes and attachment. They have what? Different shape and what? Attachment. Now, let's watch the difference between the medial meniscus and lateral meniscus. The medial meniscus has a different shape. You get? It has a different shape. It is C shape. The medial meniscus is what? Is C shape. It is what? It is C shaped or semilunar in shape, and it attaches to what? It attaches to the medial collateral ligament, and this one is more prone to injury. That is why we have a clinical correlate of the knee joint that is being known as the meniscal tear, the tearing of the what? Of the meniscus. So the medial meniscus is more prone to injury, you get, compared to the what? The lateral meniscus. Do we get? Now, the lateral meniscus is O in shape or circular in shape. It is what? O in shape or circular in shape. Then what is, or where does it attaches? It attaches at the what? At the tendon of the popliteus muscle. That is where it attaches, at the tendon of the what? Popliteus muscle. Now watch. This is the tendon of popliteus muscle. Tendon of popliteus muscle. Tendon of popliteus muscle. That is where it does what? It attaches, which is the lateral menisci. And it is less prone to injury. It is less what? Prone to injury. Get? So that is how they are being what? They are being fashioned. So the next we shall be looking on is an important outline of the what? Of the knee joint. A very important outline of the knee joint, which is the what? The bursa. So let's discuss the bursa of the what? Of the knee joint. Bursa helps in cushioning movements. So the knee joint has what? Has 12 bursas. You get? It has 12 bursa. 4 on the anterior aspect, 3 on the lateral aspect, 3 on the medial aspect, and 2 on the posterior aspect. Now, bursa. It is being divided into 4. Anterior, we have 4 bursa. Laterally, we have 3 bursa. Medially, we have what? 3 bursa. And posteriorly, we have 2 bursa. So that is a total of what? 12 bursa of the knee joint. But where I shall be delineating on is on the anterior bursa. Now, on the anterior bursa, the bursa of the anterior legion, anterior bursa. Number one, we have subcutaneous bursas. You get. You have subcutaneous suprapatellar bursa. Subcutaneous suprapatellar bursa. Number two, we have subcutaneous infrapatellar bursa. Patellar bursa. Then number three, we have deep infrapatellar bursa. And number four, we have the suprapatellar bursa. Now, these are the anterior bursa of the what? Of the knee joint. Bursa helps in cushioning what? In cushioning movement. The subcutaneous suprapatellar bursa can be called the house-made bursa of the knee. The house-made bursa of the knee. That is why we have a clinical condition of the knee joint that is called the house-made knee, which is simply the inflammation of the subcutaneous suprapatellar bursa or the subcutaneous suprapatellar bursitis or bursitis. So that is how it is being what? It is being done. We also have the Bursae bursa on the posterior aspect. The Bursae bursa is located between the capsule of the knee joint and the medial head of the gastrocnemius. You get? Because we have two joints here. Two bursa on the posterior aspect. One is between the capsule of the knee joint and the lateral head of the gastrocnemius, while the second aspect is between the capsule of the knee joint and the medial head of the gastrocnemius, which is called the Bursae bursa. Look at it here, Bursae bursa. That is how it is being done. Now, the next we shall be looking on to is the nerve supply. The nerve supply. The nerve supply. The nerve supply of the knee joint is three group of nerve. One is the femoral nerve, which is particularly from its vastus branch. Femoral nerve. Number two is the tibia and common peroneal nerve, particularly from the genicular branches. Tibia and common peroneal nerve. Then number three is the obturator nerve, particularly from its posterior division. Obturator nerve. So these are the nerve innervations of the what? Of the knee joint. The next outline is the blood supply. The blood supply. The blood supply of the knee joint is the arterial anastomosis around the knee joint, which is particularly the genicular anastomosis. You get. So arterial anastomosis of the knee joint, is it blood supply? There are so many group of arteries that forms the arterial anastomosis around the knee joint, which is the genicular anastomosis. We have the 5 genicular branches of the popliteal artery. We have the what? The descending branch of the femoral artery. We have another artery, which is the descending branch of the lateral circumflex femoral artery. We have the two recurrent branches of the anterior tibial artery. We have the circumflex fibular branch of the posterior tibial arteries. Those are the arteries that forms the what? The genicular anastomosis, which form the blood supply of the knee joint because they're wound around the what? The knee joint. The next is the movement. The movement. The movement. The knee joint perform two range of movement, the flexion and extension. The flexion and extension is actually its main and principal movement. You get the main movement. We have flexion and extension. Its principal or the main movement. The number two movement is medial and lateral rotation. Medial and lateral rotation. But this is a conjunct movement. Look at this is a what? A conjunct movement. It is not the principal movement of the knee joint. Flexion and extension are the what? The principal movement of the knee joint. You get. So that is how it is being done. The next is the relation. The relation of the knee joint. The relation. Before the relation, let's finish our labeling. This is the cruciate ligament. This is our capsular ligament. Capsular ligament. Always our femur. Always our tibia. There are subcutaneous suprapatellar bursa. Here, subcutaneous suprapatellar bursa. Now, the relation. Joint must have a relation because there are surrounding structures around it. Number one relation is the anterior relation. The number two is anterior medial. The number three is anterolateral. The number four is posterior relation. The number five is posterolateral. The number six is posteromedial. Posteromedial. Okay. Now, what are those structures that form the anterior relation? We have the tendon of the quadriceps femoris, the patella, the ligamentum patellum, the prepatellar synovial membrane or synovial bursa per se, the prepatellar synovial bursa, it also forms it, and the patellar plexus of nerves. Those are the structures that form the anterior relation. On the anteromedial relation, we have the medial patellar retinaculum. The medial patellar retinaculum. On the anterolateral relation, we have two structures, which is the lateral patellar retinaculum and the iliotibial tract. On the posterior relation, we have the popliteal vessels, the tibial nerve. Those are the structures that forms the what? The posterior relation. We also have the oblique popliteal ligament as well. It's also there. On the posterior lateral relation, we have on its upper part, we have the tendon of the biceps femoris and the common peroneal nerve. On the lower aspect of the posterolateral relation, we have the lateral head of the gastrocnemius and the plantaris muscle. On the posterior medial relation, we have these structures. You get. we have on the upper aspect semitendinosus muscle and semimembranosus muscle. On the lower aspect, we have the medial head of the gastrocnemius and the popliteus muscle. So those are the structures that are related to the what? To the knee joint on that aspect. So the next is the clinical relevance. The clinical relevance. You have the clinical relevance. Clinical relevance. Clinical relevance. Number one is has made knee. Has made knee. What is has made knee? Has made knee simply means the inflammation of the subcutaneous suprapatellar bursa of the knee joint. Number two is clergyman's knee. Clergyman's knee simply means the what? It simply means the inflammation of the subcutaneous infrapatellar bursa of the what? Of the knee joint. The next is the Baker's cyst. The number three is what? Baker's cyst. Baker's cyst simply means the chronic inflammation of the bursa that is deep to the semimembranosus. It appears as a cystic swelling that is medial to the what? Popliteal fossa. The number three is the osteoarthritis. Number four is the osteoarthritis. Osteoarthritis simply means the degeneration of the what? Of the articular cartilages of the knee joint. That is what it means by osteoarthritis. The degeneration of those articular cartilages of the what? Of the knee joint. The next is injury to the cruciate ligament. Injury to cruciate ligament. Injury to the cruciate ligament could occur in the knee joint. Because that we have two cruciate ligaments, the anterior and posterior cruciate ligament. But the one that is more prone to injury is what? The anterior cruciate ligament. You get? Now, posterior dislocation of the knee joint could lead to the what? Injury to the posterior cruciate ligament. While anterior dislocation of the knee joint could lead to the what? Injury to the anterior cruciate ligament. And when there's an injury to the anterior cruciate ligament, there will be hypermobility of the what? Anterior posterior movement of the knee joint. The next, which is number 6, is arthroscopy of the knee joint. Arthroscopy of knee joint. Arthroscopy of the knee joint simply means the endoscopic examination or the visualization of the structures of the knee joint. It is mostly seen in clinical assessment. You get? Viewing those structures of the what? Of the knee joint. The number 7 we have is knee replacements. What are those conditions that could lead to what? Knee replacement? You get? Either by a chronic osteoarthritis. You get? There could be a prosthetic implant on the what? On the knee joint. That is what we call it what? Knee replacement. Because when there's a degeneration of the articular cartilages of the knee joint, there is a need for the knee to be replaced. You get? So that is all about how it is being what? It is being done. So these are the clinical relevances that are associated with the what? With the knee joint. Now, another one is what? Dislocation. Because the knee joint can dislocate. It is a what? A joint. So it can dislocate. So the number 8 is dislocation. Number 8 is dislocation. It is a joint. So it has to do what? to dislocate. Get. Recall that clergyman's knee can be called the subcutaneous infrapatellar bursitis, while has made knee can be called subcutaneous suprapatellar bursitis. So I believe we have done justice to the knee joint, ranging from its introduction to the clinical relevance. But before I end this class, recall that there is a structure here. There is a structure here called the tendon of semimembranosus. Tendon of semimembranosus. You get. So we have discussed all in this region. I want to thank you specially for staying to the end of this class. Thank you so much for watching.